This is the Fixer Sciatica Podcast.
So this episode is coming at a very interesting time because here we are at the end of the year and many of your insurance benefits listeners will be renewing in a few days, maybe in about a week. And prior to that, I thought it would have been a great opportunity to speak with someone who is very well versed on understanding medical bills, but specifically medical bills that are tied to insurance, because medical bills that are tied to cash are very different, because when it's tied to cash, you yourself are responsible for paying, and it's a pretty straightforward contract. When you use your insurance, the insurance holders or the policy companies are organizations that hold this money and have a lot of these various different safeguards to either control how much is being spent or prevent or deny specific claims. And why is that the case? And how do we understand navigating this entire world, especially when we go into a new year? And how can we better understand these medical bills? And so today I have someone very special. We have Frank Lobb, who has very extensive experience in this realm, and he was very kind enough to share his expertise and experience in helping us understand the concept of medical bills and the world of insurance. So Frank, it's so great to see you, and thank you for being a guest on today's episode.
My pleasure.
So for the listeners out there who haven't quite heard your name yet, tell us a little bit more about yourself. How did you get involved in this world to how it led up to the conversation today?
In one sense, I'm just like the people that your classes, your listeners. I have a very broad background. I was a Navy pilot for a lot of years, and I worked for the DuPont company for a lot of years. I'm an old man. I got a lot of history behind me. But what makes me unique is that I was very involved in the negotiations for the Clean Air Act. And while I'm not an attorney, I took apart all the language and all the legislation and so forth and the law surrounding the Clean Air Act, and I got credit for standing up and reversing what EPA was doing in the way of compliance. And that was basically off analysis. Let me share how I got into this. Thought it's a good place to start. I had a wife that was very ill, and we took her to the hospital. She was near death. The good news was the doctor was able to bring her back, literally from death's doorstep, and prescribed additional care. And the insurance company that we had said they wouldn't cover it. And so I just instinctively said, fine, I'll pay for it. And the hospital refused me. To make it short and simple, I went to 3 other hospitals. And as soon as they found out that my insurance would not cover it and I was offering to pay for it, they refused me. And to make, again, a long story short, she died. And I could not understand how an insurance company could block me from paying for my own health care, in essence. So I took them into court, and I was in court against them, the insurance industry, for about 8 years, through 3 courts. I was my own attorney. And while one could argue I didn't win the case, what I can tell you is that I got access to their inner documents, and I've never found anybody else that has. And I had the background and the experience to be able to read them and understand how they're structured. They are structured entirely differently than we as the public have been led to understand. In other words, if you look at the care that we're owed from insurance, the coverage that we're owed, and the billing that we're owed is nowhere near what we're being told. It's quite different. And that got me into this and why I'm sitting here talking to you this morning.
I'm certainly very sorry for your loss. Thank you for sharing your journey with this, because it allowed you to really take a deep dive into better understanding how the insurance world works. Now, I myself, as a physical therapist, have been of the insurance-based system, I guess, if I would call it that. Early on in my career, I was working at a small family-owned physical therapy practice, and I was just a practitioner. It was early on in my career, so maybe about before 2015. And we were taking insurance. We were taking many of the major commercial insurances as well as Medicare as well. And I remember at the time I was working with They never really told us the economics behind working with insurance, but I remember going into that clinic every single day and I was treating about 3 to 4 patients an hour. And I remember prior to graduating in my internships, I would work with one patient at a time. And I found that when I was working with one patient at a time, I can actually help my patients a lot better and a lot faster. And so when I transitioned to this setting where I was working with multiple patients at a time, I realized that I wasn't able to provide effective treatment. And I actually felt like I was kind of getting run round and round. And this is actually a story that many therapists will share when they're working in a big clinic that actually takes the majority of the insurances. And the reason why I bring this up is because I remember maybe about 12 weeks after I discharged the patient would actually come back from that clinic. They would come back and say, Ashley, why did I get hit with a $2,000 bill? I thought my insurance was going to be covering this. And at the time, because I didn't know that much, I would actually say, I don't know, you're gonna have to ask the billing department. I would send them to the different part of the building. And being someone who enjoys knowledge and enjoys having the answer, I wasn't satisfied with the reply that I gave them because I said, well, I don't know, you're gonna have to ask billing. And so for me, especially when I'm taking care of someone, I wanna make sure that I get a full understanding of how they're taken care of. Obviously, one, when they're getting treatment for me, but then also ensuring that they understand what they're paying. And so that was one of the many reasons why I left the insurance-based clinic and started my own. I transitioned into the cash pay system. And really the reason why I got into cash pay system was the fact that I didn't want to deal with insurances. It sounded very complicated from a physical therapy standpoint. But also number two, I wanted to make sure that patients knew exactly what they were paying and that there weren't any sort of hidden fees, right? And so from the cash pay standpoint, literally, I provide the treatment, patient pays me cash, transaction is done. On the other hand, insurance, completely different. So for starters, let's talk a little bit more about like medical bills themselves, how they end up getting so confusing in the first place. So if you happen to know a little bit of the history, would love to learn more about that. And also even just like the history of how insurance companies work or how they came to be.
Really need to understand the history to understand how we got here, because it's more evolution than some grand conspiracy or some grand plan that someone had. Health insurance began somewhere back around the Depression, about 1930, and the hospitals needed a steady flow of money, and there wasn't sufficient access to necessary care. So for a little bit of money every month, healthcare insurance would provide all the care that an individual would need. And that's how it got started. And it was so popular that it spread across the country. Well, it's a little more complicated, but let's just look at the big picture. And about 1990, this expansion of that form of health insurance ran into trouble. Number of bankruptcies, healthcare costs were going through the roof, at least as far as Congress was concerned. So Congress turned to the insurance industry, which was basically HMOs at the time, to hold down the cost of healthcare, which, if you look at it, didn't make a lot of sense, because what you're interested in is care versus money. And the only one who can make a decision on what care is needed is a doctor with a state license. So a big hospital can't prescribe care. Only the doctors in the hospital individually can prescribe care. Well, the thing got out of whack. And there was a thing called the HMO backlash, because the HMOs began to deny coverage across the board. And the National Association of Insurance Commissioners got together and they came up with a standard contract for all HMOs across the country. It was enacted state by state. And today, every state requires essentially an insurance company to have a contract with every in-network provider in their network. Those contracts across the country are essentially identical. And it is those contracts that create the misunderstanding, because that's what defines the care, coverage, and billing we are owed. But there are the most secret contracts you could imagine. You're not allowed to see them. You can't get access to them. I have read them, but that's because I was with the DuPont company and I learned how to do this in the Clean Air Act and how to get into those systems. But I was also told I could not share the information. But but I guess I'm a little clever, because they didn't realize that these contracts are so similar that I can write a contract that's not identical to one of them, but again sends all the right messages, has the right terms, right conditions, and so forth, which is in the back of the book that I've recently written, and you can read it for yourself. And where they got to, the doctors were the only ones who could prescribe care, but the insurance company had to. Okay? So how are they going to ration care? And we know they did because in 1990, the Supreme Court, in a unanimous decision, said that basically the rationing of healthcare is the main point of private health insurance. And you don't hear that much, do you? Pegram v. Heydrich, Supreme Court unanimous decision. Anyway, how could they do it? Well, what they do is they deny payment, which is coverage, through these contracts, these secret contracts. And they can't just deny coverage, they have to deny all payment, which is what I ran into with my wife. The way these provisions are worded is if the insurance industry decides, your insurance company decides not to cover something, then the in-network provider cannot accept any money, can't bill, and they can't accept anything from the patient. But they don't tell you that. What they do tell you is on the front of say, the largest provider in this area, on the front of their emergency room, it says very clearly that you accept the responsibility that whatever your insurance doesn't pay, you pay. Okay? So let's start from the top. This is not insurance. None of these plans are insurance. Insurance requires a contract that does not exist between the patient and the insurance company. There is no such contract. The only contract is this secret contract. And we do not owe let me start the other way. You are owed all the care your doctor prescribes. The insurance company then gets the right to decide whether they want to pay for it. And to quote the AMA, most times the insurance company will pay for it, but when they don't, you have to eat the costs. That's the AMA. Very small paragraph, but I can show it to you if you want to read it. However, when the insurance company does not pay, just as the AMA acknowledged, you're not to bill the patient. And the reason this works so well is a particular facet of law in the United States about billing. If a bill is 30 days old and hasn't been properly refuted in writing, the courts are obligated to view it as accurate. Case closed. It's over. So what happens in most cases, people don't understand the bill, they make a bunch of phone calls, and by the time 60, 90 days roll around and a bunch of phone calls, the case is over. They just don't know it. Bankruptcy. And again, the issue for me is not so much doctors. Whatever the doctor has done for me, I want to pay him. I mean, I recognize I owe him something. On the other hand, when you get into hospitals, those hospital bills have been viewed by outside organizations as up to 82% in error. The Consumer Financial Protection Bureau has described them as rife with error. And this book is driven really because finally, the Consumer Financial Protection Bureau has come out and said, we have a right to understand the accuracy of bills, not knowing that the very secret contracts that I mentioned bar providing that information. So if you honor the 30 days, you put your hand up in a letter and say, hey, I'd like a little information here, they can't provide it. And for your audience and so forth, the doctors are caught in that bind as well as the big providing hospitals.
Which then brings up another really interesting question. So if we look at the typical patient doctor and billing experience, say, for example, the recording today is we're recording on December 3rd. So say, for example, we go to the doctor's office, we get the service rendered, the doctor submits billing to insurance. It ends up being about maybe 30 to 60 days, maybe even 90 days before the clinic actually even gets payment from the insurance company. So we'll say 30 to 60 days, payment gets rendered from the insurance company. From there, doctor's office or hospital sends a bill to the patient for services rendered on December 3rd. So here we are December 3rd. We get a notice from the doctor February 1st saying that there is a bill due. Are you saying that, and so what ends up happening is that here we are, we're 6 weeks post date and services rendered, Is that when the 38-day counter happens? Or is it 30 days upon receiving that letter or that bill from them? Because there certainly is a delay in payment. And so I had to ask since you did bring it up.
30 days is really measured from the date one receives notification from collection. That's how the law is written.
From collection, are you saying like the bill or like the moment that the hospital or office sends to actually a collections agency?
Back when the mail was quick, the date gets a little muddy, but basically when you receive notification of collection action, that's the 30 days. But like so many things, it gets muddy as to how the court would look at it. And the point being that if this bill is 90 days old from the date that it was written, I wouldn't want to be in court trying to defend myself as the patient that I don't owe it. The case is basically closed, and the court doesn't even have to listen to you. So the system has worked for a long time because you think it's insurance, so you naturally think you owe what hasn't been paid. Then you make a bunch of phone calls to your insurance company, and that's a mistake. You really want to talk to whoever sent the bill, the doctor or the hospital, and then you want to be more specific. I mean, the bills that you're talking about to your doctors are just getting caught up in the larger bills that are the hospital problems. I'm sure if you looked at the specifics of the billing that causing the bankruptcies and the problems in the country, they're the big bills. They're not your bills. But you can't separate them. The patients are still assuming that the insurance company is going to pay the bill, and they're not. And quite honestly, they have every right not to pay, and Congress over the years has encouraged them not to pay because it keeps the total cost, the national cost of healthcare down, or at least the way it's recorded.
So let's talk a little bit more about earlier you said that 80 about I think you said it was about 82% of hospital bills are rife with error, right? And so there's a lot to unpack there. So let's start off with just like the overall like costs. Like there's been a lot of news headlines over the past couple of years talking about how hospitals will charge, say, even $100 for Tylenol, right? Which you can go to your local drugstore and get Tylenol for less than $20 for a whole bottle of it, right? So that's one. And then it's like, what accounts for that inflated cost? But then the second part of that question is if these bills are rife with error, what would those errors look like? Is it the fact that their patients are being charged like more than they should? Are there more service codes? Like I kind of have an idea as a physical therapist on that end. That's like possibly overbilling from like excessive codes. But for the listeners who are the patients and trying to get a better understanding, like yeah, let's take a deep dive into that.
It's not too difficult on one hand and impossible on the other, which again comes back to the complexity of all this. On one hand, I've never seen a business that didn't want to bill for everything it did. So if you have a service business, and I did work in the service business for DuPont across the country, you're being very careful to ensure that all your employees and your consultants and so forth are charging for all their time and all their services. And there's an emphasis on it. You pursue it, you manage it, you enforce it. So we can't be surprised that the hospitals are billing for every nickel dime they can, because that's the system. The problem from our side is there are 77,000 different billing codes, and you can't get any agreement as to how they should be applied. So we're told as the patient, well, take a look at the bill and determine that you've got all these services and the costs are right and so forth. You and I can't get in that discussion because it's impossible. But what I would say is there's a basic tenet, at least in this country, that we should be able to get a bill that lists what we're being charged. And at the very end, you can add it up and see that the final total makes sense, mathematical sense. You never, ever get that in a big healthcare bill. You simply get, this is the bill, this is what insurance paid, this is your piece. And up to the actions of the Consumer Financial Protection Bureau over the past year, that was enough. In other words, the courts would accept it. Now you have the Financial Protection Bureau saying, all the way into collection, somebody has to take the time to come up with an honest assessment of whether this bill is accurate, so long as we ask the question. as the patient. Now, the thing I would argue here, and what I argue in the book, is that the Consumer Financial Protection Bureau has let the genie out of the bottle. We are owed through insurance, our plan, our private plan, all the health care my individual doctor prescribes as necessary. The insurance company then can decide whether they want to pay for it or not. But if they don't, I can't be billed for it. And once you get that on the table, there's a need to discuss the entire system of healthcare. The doctors are just caught up in it because you're a critical element of care.
So let's talk a little bit more about the medical necessity part of it, because I've certainly seen a lot of patients who've had procedures actually denied because the insurance company is deemed not medically necessary. And what ends up happening, well, I'll paint a scenario because this is very common, is that we'll say the listeners here who are dealing with sciatic and low back pain have had such intense back pain that it's been crippling. They're referred to get an MRI from their doctor. They've gone through their primary care doctor, they've gone through an orthopedist or a spine doctor, and the spine doctor says we recommend an MRI. The MRI is going to be helpful in helping them diagnose what needs to get done. Insurance company says, no, it's not medically necessary at this time. And what's really interesting is that here you have this patient who's going through the necessary steps to ensure that they need to get it. But all of a sudden, here's this company who actually has all the money and says, we're not going to pay for this.
This episode is brought to you by the Sciatica Protocol. Experience pain relief directly through your phone, anytime, anywhere. Interested in learning more? Check us out at ifixyoursciatica.com/the-sciatica-protocol.
In this scenario, with them denying payment or denying coverage of that specific service, it's not medically necessary. Has that denial, like the history of those denials, is it because of, in the past, of poor actors, people who were people who were charging too many MRIs, which resulted in increased costs? Or is it truly on the other end that these insurance companies didn't want to pay for these procedures? Or number three, another option is these procedures are so expensive that the insurance companies didn't necessarily see the value in paying for these different procedures, say an MRI.
Let me start from some personal experience. I told you that I lost my wife and then sued the insurance company through 3 courts. One of the things I got my hands on were the notes on that decision not to cover the care my wife needed. And I'll quote it as close as I can. She was 56, and what the note said, given her age, the cost isn't warranted. Not medical, not that she needed, but that was an economic decision. And you have, these are institutions for profit. So they're making decisions on a day in and day basis, daily basis, around their profits and their costs and so forth. And there's nothing wrong with that. That's our system. But to not understand that the insurance industry is making decisions on coverage based on money and cost would be foolish. And there are books on it. Wendell Potter and a whole bunch of people from the inside have said exactly that. I'm going to shift the game a little bit. I succeeded in life in a number of fights and battles, and I'm going to suggest here that we're talking about the wrong thing. As long as we talk about their denial of coverage, they have a contractual right to do that. They don't want to talk about it, but they're going to be very comfortable in defending it. On the other hand, when they talk about their doctor deciding it's not necessary, they've stepped out onto thin ice they can't defend because they have no standing. I don't care what their doctor says. I only care what my doctor says. So what I'd suggest to your audience and to you, you need to reverse or swing the conversation around, not to what's being covered, but what is medically necessary, where they have zero standing to make a decision. And how many times have you heard, well, our doctor says this and your doctor says that, so this is what we're going to do. No, I don't want to listen to their doctor. They have no standing. That's where I'd go with the argument because it's true. They have no position to have their doctor sitting in an office in the middle of the country deciding what I need laying in a hospital on the East Coast.
Yeah, totally understandable.
But one other quick thing I'll add, you can look in the literature and there is nothing that is more ill-defined than medical necessity, because it's an individual decision that you can't put words around. All you can do is put a doctor in touch with the patient, literally hands on the patient, and to make that technical decision, that medical decision, to the best of their ability, and that has nothing to do with an insurance company.
You brought up the cost of care in your experience. They said the cost of care isn't warranted, which then brings up another concept, or in my head, it's like, okay, well, you have the insurance company who's going to be determining whether or not they're going to pay for it. But then there's also the second part of it, which is going to be the actual, I like to call it the price. We have the cost of care, which is, let's just say, for the example, the insurance company paying it for it, but then also the actual price of the service. And so the question that I have, and you let me know if you found this through your experiences, who's determining the price of said procedure? So say, for example, the medications or even the MRIs, right? And I'll say, for example, a lot of the folks have been looking for cash pay MRIs, for example. And it's like, for cash pay MRIs, if you look for it in the San Francisco Bay Area, for a lumbar spine MRI with contrast, if you pay out of pocket, it's about $400. But then if it ends up being like going through the insurance route, it ends up being like $2,500, which gets like, we'll say like, $900 gets covered by the insurance, which means that the patient is on the hook for the difference, right? So it actually ends up being a little bit more expensive if the patient were to be going through, say, the insurance route. So the main essence of my question is like, okay, well, we have the cost of care, which is like, okay, insurances are willing or not willing to pay. But then there's also the other part of it where it's like the price of said service has to be covered for too, right? So tell us a little bit more, like, who determines that?
Well, it's two terribly different, what I want to say, almost economies. They're two different systems. If you're going to pay cash, even on the biggest healthcare bill, you can call people up and say, hey, if you'll reduce it, I'll give you 75% of it. And I think you'll get approval. So there are a bunch of companies out there who do nothing more than that. You pay me $100 an hour, and I'll make the phone call for you. And the $100 an hour was 5 years ago. I don't know what they're charging today, but they're still there. So I'm going to handle your healthcare bill, and I call up and I say, I want a discount, and I'll assure you I'll pay it, but I want the discount. So then you get the 20, 25, 30% discount, and everybody's happy. Everybody made money. So you're always going to have a lower price in that environment where you're really holding cash and you're talking to the provider directly. Now, when you're talking insurance, you have the insurance industry that wants to make money, negotiating with a provider that wants to make money, and we're now across the table arguing price in 77,000 billing codes. The provider knows the insurance company is going to short them. They're not going to pay all these charges, so they're negotiating high, and the insurer on the other hand doesn't want to pay anything, so they're trying to negotiate low. And there have been a number of articles and exposés, whatever, written about the fact that insurance is supposed to have lower prices, but oftentimes the prices are higher than you'd get if you just paid cash. And I would argue it's the market. It's these two for-profit organizations banging heads and knowing that they're not, say the one knowing that they're not always going to get paid. So they're trying to negotiate a higher price for the charges that do get paid.
Which brings up another question. It seems as if every single time that insurance gets involved, the insurance price is way higher than the cash price. Yeah. Is it because exactly of that mechanism that you described, where the organization knows that they're going to be, as you said, shorted by the insurance industry, so they end up making the price the way it is to actually account for the hours put in to try to get the money from the insurance company? Or tell us a little bit more about that.
This contract that I've mentioned basically is referred to as a provider agreement. Each state has required them to be negotiated, and then they hold them as a proprietary secret document in a state library, and you're not allowed to see it. Part is what I call boilerplate. Those are all the terms and conditions that give you the coverage and the billing and the care that you're owed under your plan. There's only one contract there. And it covers all the different plans, whether it's an HMO, a PPO, or whatever the acronym. Doesn't make any difference. That one contract defines them all. The back of that contract is a price agreement. And every year they replace the back end. So they negotiate prices. And I'm saying every year, I can't prove that, but I believe it's every year. They go back and they renegotiate or they restructure the pricing for that particular contract, just an attachment at the back, which relieves the state from the need to review it. If they change the front end, it's got to be reviewed by the state, and it creates quite a hassle. But the back end, they just tack on the back and throw out the old. So those prices that you're concerned about and that are considerably higher are just simply what are negotiated between the large providers or even the doctor. Whoever has an in-network contract has signed one of these contracts. Now, if you get down to the doctor, I can't believe a doctor actually negotiates this contract. The front part's non-negotiable anyway. I can't believe a doctor has the background and experience to be able to read that part. And the back part is pricing that he has very little to say about. So they sign it, and everybody moves on. Unfortunately, the patient never sees any of that. They just get the experience of the higher prices.
Yes, and it's particularly difficult, especially when no one ever wants to go to the doctor. No one ever wants to go to the hospital to receive care. They go because they have to, right? And so what ends up happening is that the power dynamic is very different because patients have no choice but to get these services to be done or these procedures done to manage their health. And so it's extremely confusing. I'm so glad that you're taking the time out of your day to be able to share this with us. So for the listeners out there who are coming in listening to this episode, I usually would fall into two different groups in regards to receiving care. So we have one group are the folks who actually just received care at a hospital or a doctor's office or anything that's going to be going through insurance. So they're the folks who have gone through the services and now are receiving bills. And then we have the other group who are the folks who are considering getting some sort of procedure done. And so each group of those listeners will need to approach medical billing from a certain angle or certain point, right? So let's talk about specifically for the listeners who are just received a medical bill. I don't know what this means. I don't know if I can pay it. I don't know if insurance is going to be paying it. What are some key action steps or pointers for those listeners who are trying to figure out how to navigate now that they have this bill and insurance may or may not have been able to pay for it? Now they're on the hook for a couple grand. How can they successfully navigate that realm so they can make sure that they're not on the hook for, $100,000 bill?
There are a number of things that they have to do, and it's I'm not bailing out, but on the other hand, I don't really know quite where to start. The reason I wrote the book that I just published is to do exactly what you're asking. On the back end of it is a whole list of things that you should do to protect yourself against those bills. And it ranges there are just so many different things that I find it hard for something like this to focus on any one of them because they're all important. Any one of them can hurt you. The good news for your listeners is the laws haven't changed. The doctor still works for me. Medically necessary care is still medically necessary care, and only the doctor can prescribe it. A little thing like being discharged from a hospital. Most times, you don't have to be discharged. If you need more care, forget the insurance people, just say, I don't feel up to bleeding. Because what typically happens, they'll come in and say, oh, well, the doctor's decided you can be discharged. Well, there are only two ways you can be discharged from a hospital. One, the doctor orders it, which he never does. And two, you agree on your own to discharge yourself. So if you look at the paperwork, you are discharging yourself from the hospital so that the hospital has no liability if you fall flat on your face when you go out the door. So, small point, but there are so many elements in the healthcare system that are misunderstood where they take away your rights that if you sit down, and I don't mean to sound like I'm selling a book because I'm not. I don't really care except to provide the information. If you sit down and read through that list, there are a whole bunch of things. Like a good case, when you go into a hospital, you ought to take a little piece of paper and say, I do not want any care that's not in network without my approval. And you just avoid all of these surprise bills where they have doctors in the hospitals that are not in network that will bill you directly. And you just take it off the table. But if you don't approach it like that, you're really at a disadvantage, particularly having so many misunderstandings of what the care and the coverage and so forth should be, what you're actually owed.
Which then brings up another question of there's certainly instances where people are given, say, bills from the hospital and they just straight up not pay for it. I'm going to share with you an experience when I was a student, just learning about the back end economics. I remember I was working or I was an intern at a hospital in a lower income neighborhood, but it was also they would have some pretty high profile cases. And so what was interesting is like here you would have these patients who are coming in to the ICU, which is usually like a $100,000 a day unit, right? And so you have these patients who are in the ICU and they're there for a couple of days and then they get discharged. But these folks are coming from very low income areas and they certainly aren't able to pay for it. But then also even now the whole Medicare, Medicaid, commercial insurance, private insurance, like that's a whole different discussion another day. But what was interesting was like here you have those folks, right? Folks who don't have insurance, underinsured or very low income. And then you have the other folks who are coming in who have like the private insurance and are paying out like the big top dollar. So I remember asking the person I was interning for, and I was like, I know that these patients can't pay, but these patients are racking up like 150,000, like almost to $250,000, maybe $500,000 in medical bills, and they're certainly not going to be able to pay for it. So what happens? Does the hospital just eat that cost, or like what are the economics behind that, right? And so yeah, that was a very loaded question, but I would love to hear a little bit more about that.
Okay, it's a huge problem. And look to Washington for a lot of it. How many times have you heard a congressman say, well, they can always get treated in the emergency room? If they don't have money, they can get care in the emergency room. Okay? That's false. The law specifically says that if you go to an emergency room in a hospital that's on the Medicare system, they must accept you and stabilize you. That's not treat. That just means they're to put you in a condition where you can leave. And the terminology the hospitals use is treat them and street them. That's not my terminology. That's theirs. You mention it any place to an emergency room people, and they'll understand it. Treat them and street them. Accept them, treat no more than you have to, and shove them back out the door. They will not treat any kind of care. In other words, if you came in there with stomach cancer, with pain, they'll treat the pain, give you some pills, and send you out to see your doctor who you won't be able to see for 3 weeks. That's a Washington problem. You and I can't solve that. We do not have a system for treating people who can't pay. We just don't. And we misrepresent it regularly by saying, well, you could go to the emergency room. Making this system worse is you now have doctors that are now called PCPs, primary care physicians. That doctor is to do nothing more than keep you from getting sick and treat only the most minor care, minor problems. And they have no admission privileges. It's not like the doctor I grew up with who admitted me to the hospital, tracked me into the hospital, and followed everything. It's gone. So what you have is a doctor who really has no connection with the hospital. They put you in the hospital to treat and street. And if you don't involve yourself in the hospital, you're not going to have any idea what the hell's going on. Excuse my language. You're just not. And I say that with a little emotion because I just had almost lost my wife in the hospital. And I did lose a friend in the hospital under that same set of circumstances. The only reason my wife did better is I got deeply involved. The doctor worked for me. I insisted the doctor sit down, and we went through the entire regimen of care, made some heavy decisions that he was not willing to make initially, but after I reminded him he worked for me, not the hospital, we made those decisions, and my wife is fine today. And I'm not really trying to castigate the healthcare profession. These are good people that want to do the right thing. And what I've learned is the more I understand about the system, the more I'm appreciated within the system because they're as unhappy with it as I am. Does that make sense? And I wrote the books not to sell books, but to help the average people understand how the system actually works and how you can make it work for you Matter of fact, I say a number of times, we're stuck with what we have. You and I can't change that, but we can understand better how it actually works, not how they tell us it works. And one of the statements I've made is that, matter of fact, it's on the back of the book. We can differ as to how to fix the system, but we can't let them lie to us. And the system right now is lying because they can't afford to tell us what we're really owed in the way of healthcare under insurance.
It makes total sense. And so, in essence, we have the opportunity to be able to get a better understanding of how to work with the system that we have most of the time. And I see this a lot on the professional networks being like, oh, this is how we can fight the system. This is how we can fight the system, or this is how we're a victim of the system, but not enough talk about how can we currently work with the system that we have? Because the truth is, if you want systemic change, you have to go to the higher ups. You have to go to Washington to be able to go into like talking about law. But at this time, this is all we got. And because it's all we got, books like yours gives us an opportunity to be able to say, how can we make the most out of that system, right? Which then, we've been talking about this book. Listeners are probably like, Frank, yes, I want to hear about this book. I want to hear more about this book. I want to know what the book title is. How do I get access to this? Because yes, I finally accepted that we are part of the system. And unless we go to Washington, we can't change it. So how can we make the most out of it? How do we get access to your book? Tell us a little bit more about that.
Book, the title is The Big Lie in My Healthcare Bill. And I chose that because of the healthcare billing problem that's in the country. And so I provide specific, and the subtitle is Why I Don't Know What My Insurer Fails to Pay. The action of the Consumer Financial Protection Bureau in giving us the right to request accuracy proof or proof of accuracy changes billing in the country. The genie's out of the bottle. If we understand that point alone, we have a much better opportunity or chance of making the system work for us. I then took the book and went into a whole bunch of other things that, just as you pointed out, addresses how we can make the existing system work for us, how we can extract the care we need from the existing system, because the laws that protect us are still there. The perversions within the provider, not the provider, I should say, the insurance industry, who has continually ignored the law, used hidden contracts to confuse us, all to basically cut the overall cost of healthcare in the country by rationing care. And that's not my words. That's the U.S. Supreme Court. Again, coming back to it, the main point of private health insurance is to ration care. And they cannot do that legally because only the doctor can determine the care you need, and it's your doctor. So they have to do it through the back door. And they do it by denying coverage. However, if you tie coverage to care, they're in trouble in court. So they hide it. And they insist that not only don't I pay for it, or the insurance doesn't pay for it, but the individual can't pay for it either. Okay? And that's the pre-approval. They let the hospital or the doctor know in advance that if you give this care, even though you think it's what absolutely is necessary, and it's necessary medical care by any definition, you're not going to get paid. That's the system. But if you fully understand how it works, you can work with a doctor who is, what I advocate in the book, that's your friend. You need to find a way to work with the doctor. Collectively, we need to find a way to get truth into the system so that the big players play by the rules.
Well said. Well said. And listeners, I'm going to go ahead and put the link to the book into the show notes because it's a really powerful book. And when you're dealing with pain and having to deal with doctors, the last thing that you need to deal with is to be squeezed through the insurance company or being denied care. And so, Frank, thank you so much for your time today and your expertise. I'm sure that this is going to for sure lead to many conversations. And I'm really appreciative of you taking the time and you sharing your expertise and experience. And I'm looking forward to the book that you've written to help many people really navigate this entire world of what we would call medical billing. So thank you.
To me, just stick a book up. Not that I'm selling it, but that's it. Okay? And I really am trying to just help people deal with the same kind of thing. I'm an old guy. I just turned 87. And I've seen a lot of things, and I'm just trying to help people avoid the kind of situations I found myself in. And I deeply appreciate your opportunity this morning, and I've enjoyed the conversation immensely.
Thank you.
Thank you.
Thank you so much for tuning in. We hope you got some help from today's podcast. And for more info, check us out at ifixyoursciatica.com. Have a fantastic and pain-free day. No patient-therapist relationship is formed by listening to this podcast. We are not providing medical advice, and all information should be confirmed by a medical provider.